Hello, we're here today with Ashish Tripathi, the co-founder of Tzar Labs, who have come out with a breakthrough technology in detecting cancer with just a simple blood test. Hi, Ashish, how are you doing? Thank you so much for joining us.
Pleasure, Sandhya. Such a pleasure to meet you. We've not interacted before, but I'm glad to connect.
It's lovely to have you here. Can you tell us a little bit about the cancer detection test that you have?
So, Sandhya, there is a couple of global firsts that we've achieved, actually. This is the first pan-cancer blood test, but not just that, we can detect it earlier than any known technology because we detect it at cancer in situ, which is prior to it being PET positive. So it's not visible on the PET scan just yet, but the mutation has happened in a primary organ and the cancer cells are proliferating. We can detect it at that stage. Not just that, we can tell you which cancer and where it is growing straight from a blood test. That's claim one. Claim two, this is the first prognostic test for cancer. From a blood test, not only can we tell you that you do not have cancer, we can tell you that you will not get cancer for the next 1 year because we know the pace at which these markers grow. So effectively, if you're within a safe zone, we know that you're not at risk of cancer for the next 1 year. So you can see the use case of a test like that. It's like a blood test that all of us need to do once a year so that we can catch cancer early, right, before the tumor is formed. And claim three, which is actually something that is very interesting from an oncologist's perspective, we can tell you mutations in dysfunctional pathways that you typically get from a biopsy of the tumor tissue. We give it to you from a blood test. Now, that is important because as in an advanced stage, as the doctor is trying to give therapeutic interventions, if he can actually see the impact of that medication, that actually helps guide the treatment protocol for the oncologist. So those are the three claims that we make.
Right. So can we go through this step by step to sort of just understand how these tests work? How different are your tests from other blood tests that are out there in the market? And how are they able to detect cancer at such an earlier stage? Are you looking for genetic biomarkers or are there other parameters that you're looking for as well?
So Sandhya, actually, it's been a very interesting couple of weeks since our Oxford Academia Stem Cell Journal publication got published only about 4 or 5 weeks back. The interesting thing is that we have actually exposed the science out there, and so I can speak a lot more openly about this. We are not the smartest guys under the sun. By the way, there is no test that can actually detect it this early. No one else claims to have a pan-cancer blood test. But the reason we do is we realize that we can actually detect cancer through a causative marker rather than a resultant marker, which the rest of the liquid biopsy companies in the world, not just in India, were looking at. So essentially, let me explain the nature of the breakthrough and how we actually came about it. We were literally a drug company that was working on a cancer drug. While studying the pathways, we came through a very interesting realization. We realized that the molecule was acting on a set of stem cells. And when we delved in, we realized that these stem cells this is a subpopulation of stem cells, which are creating an epigenetic change and effectively becoming cancer stem cells. The cancer stem cells are growing into cancer cells. Cancer cells, then 1 billion of them come together to form a tumor. Remember that a 1 cubic centimeter tumor has 1 billion cells of cancer. Now, once the tumor forms, it sheds its outer layers, which are called circulating tumor cells. In fact, a tumor grows at a very ferocious pace because a mature tumor is actually putting out nearly 1 million CTCs a day. Okay. Now, effectively, once the CTCs break down, because effectively they are dying cells, they have a half-life of only 4 hours. So once they break down, they release their contents, which are called ctDNA and cell-free RNA. Now, essentially, liquid biopsy companies, all the major ones that you can think of, were essentially looking at tumor and its tumor bits. So CTCs, ctDNA, and cell-free RNA. And what we had stumbled on was a causative marker because these stem cells are growing into the cancer cells, which are in turn growing into the tumor.
Hmm.
What we realized was that we could isolate these cells of interest and actually measure that specific change, right, from an enrichment of those cells in the blood itself. Now, these cells start to show up in the blood 18 months before the tumor even forms. And that is the fundamental reason for why we have got way higher accuracy than what has been claimed by other liquid biopsy companies around the world.
So,
So just making clear that it's
yeah.
not like we are the smartest guys. We got lucky. There are multiple breakthroughs like this that have happened in the past. Post-it note is not was not supposed to be a super glue, not a glue that doesn't stick, right? Well, you can tell that to the person that actually made that breakthrough and made all our lives easier. So
Yeah,
there are many breakthroughs like this, and
right.
that is essentially how our breakthrough came about.
Right. There have been a lot of breakthroughs in cancer, like you mentioned, especially in therapies and immunotherapy and things like that. So it is not surprising that there are breakthroughs in detection of cancer as well, and it's quite a positive development. So just for some context, stem cells are cells that go on to develop into other kinds of cell. And you say that these stem cells go on to develop into cancerous cells, and you're able to identify these stem cells ahead of time before they mutate into cancerous cells.
So, Sandhya, interestingly, we didn't find these stem cells. These
Hmm.
stem cells were actually found by an American scientist
Okay.
15 years back in an American university, but he had found it from tissues, right? And there are about 6,000 publications on these stem cells,
Hmm.
and they've been studied by scientists in the US, in Europe, in many parts of the world. Now, they had found it, like I told you, from tissues. Now, that does not technically have a diagnostic application, because think about it. What is the diagnostic value of a small cell sitting next to a tumor telling
Right.
you that there is a tumor close by? If you can zoom in and see that cell, you can zoom out and see the tumor. The tumor itself is so small that you're not going to see it. That was the fundamental problem with that specific breakthrough. It did not have a diagnostic application. So this is why I want to make sure that it is understood. I don't want to take away from our own scientists
Hmm.
who were able to isolate it in peripheral blood. Once you
Right.
isolate it in peripheral blood, they realize the diagnostic application of this, because essentially what we are able to do is we are able to enrich our cells of interest. And because we know how to distinguish between healthy pluripotent stem cells and stem cells that are going to be that are going to grow into cancer stem cells, right? Because they have an epigenetic change, we are able to actually look at that ratio, if you will. And that ratio essentially guides us in terms of where you sit from a
Hmm.
cancer perspective, whether it is absent, whether it is imminent,
Hmm.
whether it is present. And
Hmm.
that is the nature of the breakthrough. So this is important to note, Sandhya, because we are getting a reading for cancer as absent, right?
Right.
As opposed to, remember that all the liquid biopsy companies that you have heard of, they are looking for tumor bits in blood. What is
Hmm.
the challenge with that method? Your body, Sandhya, my body has 5.5 liters of blood. If I take out 5 ml of blood, I take out 0.1% of the total volume of blood in my body. If I see a tumor cell there, I know I have cancer. But if I don't see a tumor cell there, it does not mean I don't have cancer. It means in the small sample of blood that was taken out, there was no tumor cell.
Yeah.
Hence, the absence of tumor cells in a small sample is indicative of non-cancer.
Hmm.
Absence of evidence is not the same as evidence of absence. Once
Yeah.
we isolate our cells of interest, we physically get a reading of a specific reading that is in the healthy zone.
Hmm.
And because of that, we are able to actually give a person a reading that they are at low risk of cancer. Let me put it
Hmm.
this way, right?
Hmm.
Because technically, as we have launched the service,
Hmm.
right, we have to be particular about how we go about wording our
Hmm.
reports. But what we are able to then at least guide people is that they are at low risk, which actually can help a lot of people.
Hmm.
Because if you can do this, and as we do more and more tests, our markers become sharper and sharper as well.
Yeah. Yeah. Noted. How confident are you in saying that the tests produce 100% results? Can you tell us about the studies also that you had conducted for this?
Sandhya, thank you for asking that question because, a lot of people get fixated on that number. Please appreciate that when we did that Indian study, it was a 1,000-patient study. And we got this unique result where we got no false negatives, no false positives. And there were 25 different cancers in that study.
Okay.
Now, this does not mean that if we do a 10,000 patient study, we have actually started NHS studies. I'm actually in the US right now because we're in discussions for US studies as well. But as we do more and more studies, right, there will be reasons why in certain cases we may get it right now. But the reason we have the benefit is because our cells of interest are actually showing up in the blood a lot earlier than tumor and tuber fragments actually show up, which is why it has a fundamental advantage to what the other liquid biopsy companies are doing. But this does not mean cancer is a very complex disease. Please appreciate there are 200 different types of cancer, 3,000 subtypes of cancer. So no 1,000-patient study has covered all cancers. The only reason we believe that we may have a pan-cancer test is because what we have actually written in that report and what our theory is that the starting point of all these cancers is the cancer stem cell. So that is the common point of all cancers. Because remember, a pluripotent stem cell actually grows into all the organs and all the tissues in the body. But what people did not realize was that these same pluripotent stem cells can also grow into the cancer cells in all the organs in the body. And that was the fundamental realization that we made, and that's how we did the breakthrough. Incidentally, you raised this particular point, but when we actually took it to some of the NHS scientists, because please appreciate that our publication on the clinical study in India came out about 1.5 years back. And we have spoken with a number of scientists from Harvard, from NHS, etc. And especially after NDA, when we actually disclosed some of the steps, a few of the scientists that we have spoken to that I personally have a lot of regard for, they are high, they're very well-known scientists. And one of them made this observation. He said that so many breakthroughs happen because someone questions first principle, but the sad fact is not many people do, right? And that is the reason why we thought out of the box, and that's how we made this breakthrough. But this does not mean that if we do larger studies, we may not get some errors because, like I said, different cancers are different. But the important thing to understand is that it is giving us a very high sensitivity, very high specificity at early stages, which if you look at even the leaders within the liquid biopsy space, that has been the primary challenge. At the early stages, we're just not seeing high sensitivity and high specificity.
Okay. When you say high specificity, that is quite interesting. Could you tell us about how many kinds of cancers you detected in the tests that you conducted?
So in the 1,000-patient study, there were 25 different cancers. But since then, we have also got samples for many other cancers. But that said, we will also state that, because we realize that, post that initial study, that we can even tell you what is the primary organ and the primary, and the subtype of the disease. But that said, as we do more Western studies, this is something that we are going to actually do further studies on, because it's an entirely different application and has a major use case for oncologists. Please appreciate that the screening test is something that will appeal to people like you and me, for an oncologist, because they are dealing with a live patient. the fact that they can actually intervene differently, and data can guide their actions is very, very important. And what we are actually providing is a non-invasive source of providing some very very essential pieces of information for an oncologist.
It does sound very convenient and very useful. So this whole test is done just by taking a blood sample, right?
Yeah. So it's just we've standardized this on 10 ml of blood, right? We take 10 ml of blood. We are, but having said this, there are a lot of innovations that have happened over the last year at the back end, right? Because there are certain complications when you're actually looking at molecular markers, and the fact is that we have actually been looking at automating certain portions of it so that we actually significantly increase the number of samples that we can process. Our vision for the world is that we would like to see a world where all 8 billion of us are doing this test once a year, because we believe that if we can do this, we would turn cancer into an early stage disease. And that's a great goal to have. But what that also means at the back end is that there has to be a lot of process innovations, which our team needs to achieve, because and a lot of automation. And that is essentially what the team has been focused on.
Absolutely. And I would assume that at some point, if you would like to scale it to, say, a national level, or like you said, a regular test that someone takes every year, I would think you would also probably need to work with public health officials. Do you anticipate working with government and officials that way in the future?
So our view is that in the immediate, our immediate goal is to do the NHS trials. Our belief is that, when you get Western ratification, you get a lot of support for innovations like this, even in India and other countries. The reason being that this kind of innovations have typically been made in the West, and they have specific paths, right, and certain rigor that they actually put you through, which is good. And so our immediate focus is to actually look at doing NHS trials. But we have been guided well by some of the scientists that we have spoken to out there. What we've been told is that don't immediately claim imminent cancer, because please appreciate that we will have to do longitudinal studies for that. Right? But the fact is that if you can just tell a person at stage 1, right, that you have cancer present, you have cancer, right, that can actually allow for interventions at an early stage and frankly save a lot of lives. The guidance that we were given was that focus first on cancer present and cancer absent. As time goes on, of course, the use case of imminent cancer will be of major interest, right? Because we believe that that's at that stage, the cancer is actually a weak disease. And so our logic is that if we can detect it right at that stage, and we can work with biotech companies to actually intervene at that stage, I think that would be an ideal scenario. Think about it from the perspective of a cancer survivor. A cancer survivor lives with the risk of that cancer coming back. And when it comes back metastasized, because it will grow in a non-primary organ. And that is, and if you catch it late, that is a dangerous situation to be in. And, like so many people, we ourselves have suffered from within our family. So this would be important for us. We want to be able to do this for cancer survivors. But that said, not just cancer survivors, for people like you and me. Why wouldn't we actually just do this test? Because this is, this disease, if you catch it late, just look at the statistics. I mean, you're dealing with a disease that goes downhill very, very fast.
Yeah.
And the later you catch it, the lower the chances of survival. The cost to the patient, their families, is horrendous. So that would be our goal. But this would be something that would appeal to people like you and me, right?
Absolutely, yeah.
From a doctor's perspective, they're more interested in the all organ biopsy part because we can help in their thought process from a therapeutics perspective.
Yeah, got it. If so I do want to take the BRCA gene test, and I would, if I took your test as well, just specifically with respect to breast cancer, can you just walk our viewers through how the results would be different, how they would be similar, and what are the different ways that we can interpret your test results versus, say, a regular BRCA gene test?
So again, very good question. Incidentally, BRCA is still a exome marker. So it is, it is still the propensity of you getting a disease. Now, high propensity, I grant you that, right? But it is still the propensity to get the disease, not certainty, right?
Okay.
And essentially, many famous people have, intervened at that stage.
Yes.
But let me put it another way. It is the same when it comes to, so BRCA is typically actually used as a corollary for breast cancer.
Yeah.
Right. Now, that said, similarly, someone could be doing a colonoscopy very, very religiously because there's colon cancer in that family. Consider now for a fact that, a person may continue to do this for 5 regular years because they are they're being very careful, not knowing that at that particular point in time, they have already developed a liver cancer or a kidney cancer or a brain cancer, right? So if I can put it this way, there is value in a common test for cancer because that, you cannot possibly cover all cancers because then you would actually do so many multiple tests.
Yes.
If you can actually do one common test and then as a follow-on, because we believe that, look, because remember that there are 2 successive, there's an HRC test, then there's an all organ biopsy test.
Yeah.
HRC tells you where you sit, cancer absent, imminent or present, but or actually a risk weighting for that. But the all organ biopsy actually indicates the primary organ, right? And now with that, you can do follow-on tests to confirm. And I can tell you, not just for breast cancer, there are other such tests for other cancers as well, but not for all cancers, right? But the point is that you can actually do follow-on tests, and the reality is that if we are indicating the HRC is above 10, then we would immediately guide that patient, that person, to go and do a PET scan because we can actually locate where that particular cancer, that person's cancer is.
Yeah.
But all up, our efforts are all about trying to actually detect it as early as possible. And we believe that is the core thing.
That sounds
so
really...
Can I answer your question in terms of, BRCA is still a particular type of cancer?
Yes. Yeah, definitely. Definitely. This is a pan-cancer test, and BRCA, like you said, is a particular type of test. I was wondering, so like you said, BRCA tells you the propensity or the probability of you getting breast cancer or ovarian cancer. And so I just wanted to distinguish the results of BRCA test with the results of your test. How do we interpret the results of the 2 tests?
So effectively, Sandhya, by the way, that's a good question, but this is something that I would actually like to speak to with some of my doctors rather than actually giving a wrong impression, because I just want to make clear that I'm not a doctor, right?
Yeah.
I just know a lot about this technology because I have seen it through its development phases, and I've actually spoken to so many doctors and scientists. But I would prefer to actually find this out. I'm just trying to give you a broad impression
Okay.
of where the limitations are with BRCA. BRCA does not necessarily mean that you have actually got cancer.
Yeah.
Right? It's
Yeah.
zone, right? So it's the risk of getting a specific disease, and grant you more than normal levels of risk,
Hmm.
right?
Yeah.
If you have a mutation.
Yeah. Yeah. The test that you described, your test sounds extremely useful, and I'm sure that you are planning to scale it up. Can you tell us a little bit about your efforts for the next few years, say the next 5 years? Are you planning to conduct more tests? Where else are you planning to open up centers? What labs do you have going on right now?
So interestingly, we have actually been approached by a number of countries and a number of regulatory bodies to do joint studies with them. Our immediate focus, however, is going to be with NHS and also in the US, because we believe that once we get the US and European ratification, it's easier for us
Yeah.
to actually in UK, given once we have that data, it I think what you will find is that a lot of people are still, hesitant about, whether this. I mean, they're hopeful, right? Because who hasn't been touched by cancer?
Yeah.
But that's what really matters to them is a Western ratified study. So immediate focus is that. But that said, once we are able to show it even in one cancer, right, that we are getting the high levels of sensitivity, what we have been advised is that, look, I mean, there are 100 million insured patients in the US alone. All of them do a blood test. So the reality is that what is going to happen is that increasingly, a lot of them are going to want to do it for different cancers. Now, most the first focus is going to be on some of the really terrible cancers. And
Such as?
pancreatic cancer, ovarian cancer. So, the immediate goals are colorectal cancer, lung cancer, and so on and so forth. But, there are certain cancers that are impacting a lot of people. And unfortunately, the consequences of detecting it late are pretty bad in terms of survival rates of the patient. So that is going to be our first focus, because like I said, it is easier for us to actually get a particular cancer study passed rather than a common test for all cancers. Because think about it from a clinical perspective, what that means is that we need to actually have statistically relevant numbers of all the cancers, and that would just elongate the study. So it is better and smarter for us to actually go cancer by cancer. But I think what you're going to find is that once we are able to prove it in a Western setting, we've been advised by multiple people that you would be put on an accelerated path, because there are a lot of people that are dying from cancer and could be saved.
Yeah, it is indeed true that, when you have the evidence and you publish in a reputable journal, it does get a lot of attention and acceleration. Surely, yes. Yeah. What are the kind of people that you've used in your tests and your plan to, the demographics?
So to be very candid with you, the way this works in clinical trials is that we don't actually select the patients.
Yeah,
right?
the hospitals.
The CRO or the hospital will. Now, but what we can see from the design of studies is that they are actually trying to make prospective patients that are currently coming into the system, right, as high risk patients, right? Because that would be the as real a situation as a let's say an NHS system or a US system could actually visualize, right? People are coming in. Some of them are going to be, let's assume from colorectal perspective, a benign adenoma. Some will be colorectal cancer. How, if you can actually take a blood sample, and we can actually show that we can actually give you results faster and more accurately, right, as compared to anything else, right? Because the other processes, as you know, are either invasive or, um, you know, for instance, the
Yeah,
fit test, colorectal, and so on and so forth. So the idea is to compare a like-for-like comparison. And if you can genuinely show that you are getting these high accuracy results, then which system would not want it
true,
introduced, especially
true.
in the West, where they have active screening processes. And the way we see it is that once we break into that system, you're going to see a huge application. Because right now, I think it would be more personal interest,
Hmm.
where in places like India, where we may actually choose that I want to get it done because I don't, I've known people that
Hmm.
have relate, etc. So but what we believe is that increasingly it'll become a systematic path in multiple countries, because there's a cost to the system, right,
Yeah.
of detecting it late.
Yeah, that sounds really wonderful as a future plan, and I do hope that works out because cancer has been plaguing us for millennia, and we're still, like you said, every single person has been touched by cancer. So as more and more breakthroughs come along, it does feel very promising that we're sort of, making a lot of progress in the field.
So
So
it's
if
the second
someone,
largest killer, by the way. It's the second largest killer in the world, but in the Western
yeah,
world, it's
absolutely.
the largest killer.
Yeah.
Um, and in fact, if you just look at the statistics of what the projections are in terms of cancer numbers over the next, it's becoming worse and worse.
Yeah,
Uh,
and this is still human cancer only. Yeah. So if someone wants to come and take a test from you right now in India, what can they do? Do they come to your Mumbai lab? Do you have other labs? Do you plan to open other labs soon?
So Sandhya, we do, but right now the only lab that can do this test is actually our Mumbai lab.
Hmm.
In one sense, it's satisfying to say that, but we believe that we want to actually build capacity. We have done agreements with a lab in the UK. We're
Hmm.
also in discussions with another lab in the US as well. But interestingly, there have been some very interesting conversations, even with larger firms.
Hmm.
But um, as you can appreciate, my core priority is actually the Western clinical studies, because
Hmm.
I think that actually uh, changes the game
Yeah,
from
absolutely. Yeah.
the perspective. So
Yeah.
that's my aim. But yes, if you want to do it, the only lab you can do it at is India. Now, what's happened is that over the last couple of weeks, we've just had so many people apply for wanting to do this test, that we've unfortunately got quite a waiting list, because there really is, there's a capacity constraint that we've got.
Yeah.
But that said, we've actually done certain agreements with a US company, for instance, and we are getting certain machines delivered for the very first time, by the way, in India, and which will automate
Hmm.
um, parts of the process. So we
Hmm.
will to do higher capacities, and our view is that we will actually open we will open multiple labs after that. So the
Hmm.
first was standardizing the process in our first lab, but we are going to open other labs as well.
That sounds really promising, Ashish. I wish you all the very best. The test sounds very promising. The fact that you're having labs in India also sounds very hopeful. And I learned a lot from this conversation. I hope our viewers did as well. Thank you so much for joining us, and all the very best for your initiative. We hope to hear more from you soon.
Thank you so much, really a pleasure.